moderering blandat ner den där. Nu måste den vridas lite grann sådär.
Ja, men nu är det på. Så. You can start now.
Ja.
Mm?
Ja.
You just start.
Yes. I will answer some questions from my followers. And the first question is, what is the flexion distraction technique for treatment of L5-S1 disc herniation and sciatica? And the flexion distraction technique was developed by Dr. James Cox, an American chiropractor who sadly passed away 3rd of March this year. And I had the opportunity to follow one of his seminars a few decades ago. And his method of treatment is using the flexion distraction technique to create a negative pressure inside the intervertebral disc, which can be very helpful for a patient who suffers from pain from disc herniation. By creating a vacuum or a negative pressure inside the disc, the theory is that the disc herniation can be somewhat sucked back into the disc, and the size of the herniation can be diminished a little bit. In most cases, you don't need to decrease the size of the disc herniation very much to get a very good relief of the symptoms. And Dr. Cox's method was to use the flexion distraction technique, which is a technique whereas the patient is in the supine position with face down, and the lower part of the chiropractic table is hinged and can be angled downwards. So the patient lies with the segment that is needs to be treated exactly where the angle of the table will be. So by lowering the lower part of the table, the lumbar spine will come into flexion, and the posterior elements of the intervertebral lumbar segment will separate from each other, and thereby creating a negative pressure inside the disc. And Dr. Cox's method was to use the flexion distraction quite frequently. Sometimes he even treated his patient twice or even 3 times daily to continuously develop the vacuum or negative pressure inside of the disc. And he also used the strategy of quite a lot of rest for the patient. The affected disc should not be under so much pressure and strain. It should rather be relieved from all kinds of strains and pressure. So his strategy was quite different from what is considered the mainstream strategy for treating back pain today, which is activity and training. And in my opinion, Dr. Cox was very right and on spot for treating the disc herniation, because when you have a disc herniation, all kinds of pressure inside the spine and inside the nervous system can cause a pressure to the compressed nerve root, and thereby increasing the pain. And by decreasing the pressure on the lumbar spine, you can decrease the pressure on the nerve root and thereby decrease pain. And by decreasing the pressure on the nerve root, the inflammation and irritation can also be relieved. So Dr. Cox's treatment was quite an extensive protocol, and his his aim was to reduce the symptoms by 50% on the visual analog scale. And if he was not successful to decrease the patient's pain within 2 weeks with at least 50%, then he considered his treatment unsuccessful, and he recommended further diagnostic imaging and further references for his patients. And the next question was a patient who approached me and over the internet, and was disappointed with a treatment that she had received from a chiropractor who practiced in a way that was quite different from my usual treatment for low back pain, and it was not either the treatment that Dr. Cox would give for nerve root pain. This chiropractor that this patient met, he treated her with a device that was in metal with like a rubber end to it, and it was giving small shots like boom, boom, boom on different parts of the spine. And this patient had expected a treatment where there would be quite a lot of motion in the spine, and expected to hear some cavitations and a lot of noise for the adjustments. So she was not getting what she expected, and she did not feel that she was getting the results she had expected from the treatment. And that is also always the case, that when we start a treatment, and if we do a few treatments and the patient does not seem to respond to the treatment in a positive way, then we need to change our strategy. Either we should try to do another treatment strategy if we have an alternative treatment for the condition the patient is suffering from, or we should recommend the patient to seek help with another practitioner who maybe uses another kind of treatment that might be helpful for the patient. But I recognized this treatment the patient was getting as something that is called the activator technique, and that is a quite common technique to use among chiropractors. Some chiropractors use the activator technique for some patients and not for all patients, but for the patients that they deem suitable for this technique. But there are also chiropractors who use the activator technique as their main strategy for treatment. And the activator technique should be used according to a certain protocol. It's not like you should just put the activator on any part of the spine that you think should be helpful. But there is a very strict protocol with diagnosis and treatment for different conditions that should be followed. And the practitioner who uses the activator technique should be well educated in the activator system. And if the chiropractor is well educated and skilled in using his activator technique, then the technique can be very helpful for patients. And it is also a very, very soft and gentle technique that is very popular, especially among patients who are a little bit afraid for the more hands-on treatments that chiropractors like me use, which causes a lot of noise when treating. And another question that came from one of my followers was a question if we can diagnose a compressed nerve root in the L1, L2 region without use of the MRI imaging techniques. And diagnosing nerve root compression for the lower lumbar segments is, I shouldn't say easy, but possible and quite obvious if all the signs are in place. But the L1 and L2 dermatomes are a little bit more tricky because they don't usually give very obvious signs. And the pain from the L1, L2 dermatome goes from the back and a little bit to the front, like over what is considered the hip and into the groin. So nerve root pain from the L1 and L2 area can very often be mistaken for hip pain. And the motor function of the L1 and L2 is mainly hip flexion. So the patient with L1, L2 nerve root compression can have decreased strength in hip flexion, which is not very often tested by the practitioner and should not be forgotten when you treat patients with back and hip pain. And there is also one reflex with the L2 dermatome, and that is something that's called the cremaster reflex. So the cremaster muscle is a muscle that is like wrapped around the scrotum, and it will lift the scrotum into the abdominal cavity if the muscle is strongly contracted. The muscle will contract. So that is, for obvious reason, a reflex that is not very frequently tested. So to sum it up, the L1 and L2 dermatomes can be quite tricky to diagnose, but it can be very helpful because if you give treatment to the area, like treatment for decompression, it's quite difficult to find a good nerve mobilization technique for the L1, L2 nerve root. That might be hip flexion, but it doesn't work so well. So, but if you do traction and adjustments to the L1, L2 area, you can very often get very good results for pain from the L1, L2 dermatome. And I have also, one of my patients had been suffering from hip pain for a prolonged time, and finally she met up with a very skilled surgeon at Sofiahemmet, a back surgeon at Sofiahemmet, who diagnosed nerve root pain from the L2 dermatome, and she was treated with neural blockade of the L2 dermatome, which immediately relieved her hip pain, which had been for almost years been treated as trochanteritis, which was a mistaken diagnosis where the pain actually was a nerve root pain. So you should always consider the nerve root when it comes to pain in unusual areas of the body. And our next question was linked to what I just spoke about, and the question was tell us more about nerve mobilization for sciatica, and that also brings to mind another colleague who has sadly passed away, but many years ago, and the theoretical basis for nerve mobilization is based on the work of Professor Alf Brieg, who was a neurologist, a neurosurgeon and researcher who was based in Göteborg and published his works in Göteborg University. And he published a book in 1978, and the title of the book was Adverse Tension of the Central Nervous System. And in that book he wrote about his research on the 10 different types of tension that can cause symptoms and illness from the nervous system. The most serious tension that can occur is, of course, by accidents, and also illnesses like the Arnold-Chiari syndrome and the tethered cord syndrome, where the nerves and the medulla and the spinal cord is compressed and pulled by adhesions inside the spine and skull. It causes very severe symptoms. But these findings also apply to nerve compressions and compressions of the spinal cord that can be caused by disc herniations and spinal stenosis, and even by swelling inside of the spinal column by the venous plexus that is inside of the spinal column. And the work that Alf Brieg did formed the basis for the development of the nerve mobilization techniques that is used by chiropractors and manual therapists and physiotherapists all over the world. So a great thanks to the researcher Alf Brieg, and it's also a reminder of how important it is with research, and that you can never be really sure, well, what the research you are doing will lead to in the future. And we have another question. Do we know? Yes, we have a question also. Everything comes together. It's about hip pain. So if you actually have trochanteritis, and it is true trochanteritis and not the nerve root pain from the L1 or L2 nerve root. So the question was, how should we stretch our gluteus maximus to help us who are suffering from trochanteritis? And the answer is that you shouldn't stretch it so much, especially not if you have an active inflammation of the trochanter bursa. You should rather work the gluteus maximus rather than stretch it so much. So you should do maybe, say, 80% activity and training and maybe 20% stretching only. And I have also recorded a YouTube video with some suitable exercises for the muscles of the hip that is involved in trochanteritis. So and those are activity exercises that trains the muscles like the gluteus maximus and the gluteus medius in particular, and also a little bit of stretching, but like I said, the focus should be on working the muscle rather than stretching it. Thank you.